And we should be all set. All right, there we go. Again, good afternoon, everyone. Thanks for joining us. We just have a few quick slides to go over before we get into our session today. So I just wanted to introduce the board to you. If you don't know them yet, just take time to connect with them on LinkedIn and see them in person and thank them for their service and their volunteering. We are an all volunteer board, so appreciate all the hard work of everyone to manage our events and help our members connect and be able to advance their career. So our next slide, we have several ways for you all to connect with us. So LinkedIn is our method of choice overall, but you're welcome to check and link with us on the other sites. But LinkedIn, just search on ACHEMT, and it's easy to connect with us. And we do post a lot of information about upcoming events and also sharing some of the successes that we've had and celebrating our members that get their fellow certifications. So be sure to get involved and get connected there. And for those of you that may not be aware of the fellow certification, the American College of Healthcare Executives provides the only nationally recognized healthcare leadership certification, and it's called a fellow. You might see people's signature lines say FACHE, so that's a fellow of ACHE. And if this is something that you have not been aware of, I encourage you to go out to the ACHE website, look about FACHE or about the fellow, learn more about it, and then set up your career goal to achieve that certification. It is a lot of work. It does take a while to plan and make sure you go through and have the education you need and the volunteering, and there is an exam, and they're studying for the exam. But we've got a great career development committee that has a Board of Governors review course that you can attend and participate in, and we have folks on our board and in the chapter that can help be a mentor for you as well. So highly encourage you to achieve and work towards your fellow. Special thank you to our sponsors. So we have LifePoint, HCA, TriStar, CHS, Lipscomb, Turner, and LBMC. And if anybody's interested in having their company be one of our annual sponsors, the sponsorships help underwrite a lot of the programs that we provide for a reduced fee for our members. So it's very important, and we want to thank them very much for all that they do for us. With that, our session today is leveraging the lab and pharmacy to improve the health system, patient outcomes, margins, and provider satisfaction. And I'm going to introduce Trent Beach. He's a PharmD, Executive Director of Pharmacy of UNC Health. And Trent is also a former president of the chapter, and most recently is now a Regent alumni. So that's what I'm going to say now, President alumni and Regent alumni. So without further ado, I'll turn it over to Trent.
So thank you, John. It's really great to be back with the chapter, to have the opportunity to go through this. Really, what I'm going to say is an engaging discussion that we'll have today. What we're going to seek to do is to challenge you to rethink the operating models of our emerging healthcare environments, even as we think through today's challenges, where we're seeing record issues with recruitment and retention, stress, burnout, waning engagement from our teammates. But one of the things we want to ask is, where are we now? And as you know, we're seeing increasing market transition away from fee-for-service towards risk-based models. These are still our reality, but we're definitely seeing shifting away. We're also seeing more widespread adoption of team-based care. We're seeing greater leveraging of the underutilized advanced skills of our pharmacists and clinical laboratory experts. We're seeing accelerated emergence of machine learning, remote healthcare, telemedicine, at-home health services, digipharmaceuticals. Digiceuticals is kind of FDA-cleared apps that require a prescription and then a pharmacist patient follow-up. And then we're also seeing lots of smart devices coming out, whether they're wearables or like the smart seats and smart mirrors that pick up pulse, blood pressure, and can then wirelessly send that to healthcare providers, including those of us online, where we can actually assist in the medical care. And we're also seeing an uptake in personalized care, healthcare, which is unleashing the power of our individual genomes. So the primary question that we've assembled our panel today is we want to explore what is the impact of this acceleration of technology, digitization, personalization on healthcare. And then secondly, how are the shifts we're observing in how and where care is planned and received impacting our strategic plans and our systems? So in today's program, we want to touch on those impacts. We want to envision where we might be heading. We want to propose new perspectives on some of the traditional views of our clinical services from clinical laboratory and pharmacy. And so with that, I would submit 4 assertions to you. As we embrace precision therapy, the roles of pharmacists and delivery systems, which we're currently familiar, you sort of have those images in mind, they will continue to shift. The first thing I would say is, as pharmacy expands beyond chemical and biologic solutions, I foresee adding digital therapeutics, programmable bacteria, things like additional nutraceuticals, implants, and even gene editing that will impact where we go in the future. Second, I think as locations where we plan and deliver healthcare continues to shift to ambulatory and even home settings, I anticipate continued consolidation of retail pharmacies as health destinations, and product distribution will be altered by kiosks and telehealth. I anticipate we will see 3D printing of drugs and even same-day delivery of drugs to homes through driverless cars and even drones. 3, I see AI algorithms and continued development and advancement in automation will enhance our pharmacists' responsibilities and further strengthen the case for CMS to recognize pharmacists as care providers and ultimately to prescribe acute medications and manage chronic diseases. In a situation where we have a healthcare system where we have access issues and healthcare disparities, this would be a much needed augmentation. And fourth and finally, before I introduce our speakers, as we envision diagnostics, we should think about the changes we saw in another sector, that of the auto industry. Now, I'm not saying that auto care is the same as patient care. What I would have you consider, though, is the length of time cars on the road today and how they compared to decades ago. With the rise of quick, readily available diagnostics and easy, convenient maintenance, such as provided by companies like Jiffy Lube, for instance, on almost every neighborhood corner across the country, we've seen an economic lift in our cars' health. There are healthcare models today and even expanding where ready access to diagnostics and self-diagnostics, interpretation of results, and implementation of health interventions in the community and even at home are and can have significant impact on our community's health. So I would ask you all to consider this question. How are your organizations addressing these? And are you ready for disruption? While you're contemplating that, allow me to welcome to the stage our expert panelists. I would first like to introduce Dr. Keith Laufman. Keith is founder and managing partner of Continuum Consulting Partners and CEO of InSyncDX Solutions Incorporated. He has numerous president and CEO level leadership positions in both for-profit and not-for-profit healthcare settings, including Mayo Collaborative Services, Ameripath Incorporated, MedFusion, and SunQuest Information Systems. He has a record of advising clients and leading companies in maximizing efficiency by reducing care variation through 1, diagnostic optimization and synchronization, 2, growth through diagnostic integration, and 3, profitability by focusing on aggregate costs of patient care. Keith has extensive expertise in strategic planning related to value-based care, business plan execution, evidence-based performance to maximize the customer-patient experience, and change management, emphasizing organizational alignment and enhanced provider engagement. Welcome to the stage, Keith.
Thank you, Trent.
I would like to next introduce Dr. Les Wold. Dr. Wold has held numerous healthcare professions during his more than 40-year career as a member of both for-profit and not-for-profit organizations. During his tenure at the Mayo Clinic, he was chair of the Department of Laboratory Medicine and Pathology, chair of Mayo Medical Ventures, chair of Mayo Collaborative Services Incorporated, and a member of the Executive Committee and Mayo Clinic Board of Trustees. In all of these roles, he focused on diagnostic optimization and care coordination across the continuum to ensure that the patient's needs came first. This focus has reinforced his belief that data-driven decision-making and the use of tools such as diagnostic pathways, reflex testing protocols, and effective alerts generated by the clinical laboratory are an essential part of improving care delivery for patients and providers. After retiring from the Mayo Clinic, Les has continued to lead professionally as CMO at Jari Research with Vital Health Software and a special advisor to the Novar Foundation. In these roles, he has had the opportunity to see how provider engagement is central to the successful transformation of healthcare systems around the world. He has an abiding interest in leveraging data to better support the needs of patients and providers. And with that, I'd like to welcome Dr. Wold to the stage.
Thank you, Trent.
And our third panelist is Dr. Anthony Morial. Dr. Morial serves as the Associate Chief Consultant for Clinical Pharmacy Policy and Pay for the Department of Veteran Affairs Pharmacy Benefits Management in the VA Central Office. He has led multiple initiatives focused on organizing, standardizing, and expanding the scope of clinical pharmacy practice throughout the VA. His accomplishments include creating the first VA pharmacoeconomic and pharmacogenomic pharmacist positions, serving as a founding member of the VA's National Formulary and PBM Outcomes Research Group, establishment of the first accredited oncology, pharmacoeconomics, pharmacogenetics, genomics, nephrology, and clinical informatics residency programs in the VA. And then finally, the establishment of the National VA PBM Clinical Pharmacy Practice Office. And that office has been responsible for significant changes in pharmacy practice in the areas of primary care, mental health, antimicrobial stewardship, and many others, and more recently, pharmacogenomics. He holds board certification in pharmacotherapy, as well as external certifications in pharmacoeconomics and pharmacogenomics, and complementary and alternative health. He's also certified as a pharmacy executive leader and recipient of numerous of the profession's highest awards. He has authored or co-authored over 70 peer-reviewed articles, has served on editorial boards and a reviewer for a number of journals, and has been involved in leadership roles in many pharmacy organizations, both nationally and internationally. So want to welcome you, Anthony, to the stage.
Thank you, Trent.
So I'd like to jump right into the topic, and if I could ask each of you to take a moment for your opening comments, addressing your perspective on today's topic. Dr. Wold, would you kick us off?
Sure, thank you, Trent. You know, the role of the pharmacy and the clinical laboratories historically has, at least from my perspective, been kind of behind the scenes. And things have changed dramatically. The change in the workforce, et cetera, means that healthcare leaders at a hospital or healthcare system level can realize significant advantage by changing the way in which they view the role of both the clinical pharmacy and the clinical laboratories in the future, leveraging those capabilities for the improvement of both patient care and the financial well-being of the organizations they lead.
Thank you. Dr. Loftman?
Sure. Yeah, thanks, Trent. Yeah, obviously we will and are experiencing tremendous transition in healthcare, and frankly we need to. As we all know, the based on per capita costs, we're higher than the other industrialized nations, and our life expectancy has not improved in a linear manner. So there's opportunity to improve. And the good news is, in the middle of this change, there's significant opportunity. And I think the things in healthcare that we all look at and say, gee, this is frustrating. Why do we do it this way? Why do we do it that way? And this is an opportunity to reposition that. And I think both pharmacy and the laboratory will play very different roles going forward, and very important roles to extend and just take advantage of the leverage that these two professions bring to healthcare that maybe fee-for-service didn't fully recognize because it wasn't necessary in cost-based fee-for-service.
Thank you. Dr. Morial?
Yeah, I would say, although there are a lot of trends impacting the healthcare models today, you know, pharmacy has shifted from a product-based profession to a clinical profession. And that started to be driven in the early 2000s by all schools of pharmacy becoming doctor of pharmacy trained individuals and focusing on pharmacotherapy and the best way and most effective way to treat patients. And as was mentioned, you know, the healthcare systems have not always leveraged the new training and expertise of these pharmacists, but we are seeing significant changes in the way that's happening. And I'll be able to describe some of those as we get on later. But it's also been exacerbated by the demographics of patient populations, the number of new medications coming to the market, as well as provider shortages in the other professions, which really forces us to rethink how care is being delivered. And it has resulted in tremendous changes in the scope of practice authorized for pharmacists at both the state and national level.
Thank you. So as we look at healthcare today, and some of you noted this, we're seeing really significant professional shortages. And as you noted, movement away from fee-for-service and dramatic technological advances. How are these trends impacting the care models today, and what do you see in the future?
So I'll take a shot at that, Trent. These trends are actually not new. There's been concern about the number of laboratorians for a long time. There is, I would say, at least optimism, at least cautious optimism about the way that we can better leverage the tools that the electronic medical record can provide to providers across the spectrum of care. Now, it's not easy, but it does require leadership to make a sort of paradigm shift in how they view both the roles of the pharmacy and the clinical laboratories. And if you make that paradigm shift, you can actually offload things from providers primary care providers and specialists, and make it easier for them to deliver care. So the shortage is real. There's no question, but there is a solution, and it largely leverages technology, in my opinion.
Thank you,
And
Dr. Morgan.
yeah, I'll just chime in a couple of things that, obviously there's some dynamic changes going on, but kind of from a clinical pharmacy perspective, first is the explosion of pharmacotherapy and evidence-based medicine, which means that nowadays almost all diseases are treated with medications. And that wasn't the case, 15, 20 years ago. And so the proper selection, dosing, monitoring has created a tremendous need for clinicians who are trained specifically in medications. And, the pharmacists, as I mentioned, with their Doctor of Pharmacy degree, are the experts in medications. And so I think the primary care and specialty care providers are recognizing that, they are great at diagnostics and even maybe the initial selection, but they could really use the pharmacists to do the titration and monitoring and all that to offload them. So when you think about pairing the pharmacists with these providers, you get a powerful and efficient system where the pharmacists are managing the drug therapy and let those clinicians focus on the diagnostics of new patients, which they're often overloaded with. And then, lastly, I guess I would say that, we're fortunate at the moment in this current environment that pharmacists are one of the few healthcare professionals that are actually not in a shortage supply nationally. So as we find ourselves in a position where specialist providers, mental health providers, primary care providers, nurse practitioners are all in a shortage situation, if we can use the pharmacist as a force multiplier, we can both lower cost, improve care, and reduce burnout and stress on those providers that are available.
Trent, I might just add to that along the lines of staffing and patient satisfaction, I think we should not overlook patient satisfaction as that becomes more and more important going forward. And with new technology to help scale the system, we can leverage more virtual care. And we certainly saw that in the pandemic. It accelerated greatly, even though it was in the wings. And my opinion anyway is that genie is not going to go back into the bottle, and because patients prefer it, and I think it is a way to scale staff. And the laboratory, in changing its operating model, is in a great position to support these trends out into the community and into the ambulatory setting. And I think in doing so, it can help the various team members that both Les and Anthony have described, as well as the broader care team, to really work at the top of their license and to try to eliminate some of the frustrations which are really driven by administrivia and fragmented process. And so moving toward a more integrated, streamlined delivery system can eliminate a number of frustrations. And we'll see a little bit later, some of the characteristics of the laboratory position it extremely well to play in that role.
Yeah.
That's really interesting. And I believe in the team-based care model. Let's explore a little deeper in how would pharmacy and clinical laboratory be specifically, how would they be leveraged to enhance the patient outcomes and reduce episodes of care costs?
Trent, I'll take another shot at that first, and Keith and Anthony can add their own perspective. But I really believe that there's a growing body of evidence to show that the clinical laboratories can help in terms of sending alerts that may help identify patients who are at risk for future events that can be avoided by an intervention. And as as an example of that, I would suggest that, for example, NephroCheck is a test that can be done post-cardiac surgery to help identify patients who are at risk for acute kidney injury. If you have acute kidney injury post-cardiac surgery, you have a longer length of stay. It has a dramatic impact on the overall cost of care. If you can have an early intervention, and it may be a pharmacological intervention, certainly an intervention related to fluids, et cetera, you can reduce that length of stay or the risk of the extended length of stay. The other clinical laboratory tests can also identify patients who are at significant risk for increased length of stay. Something as simple as a serum sodium can identify patients who have hyponatremia or low serum sodium. Those patients across all admitting diagnoses have a longer length of stay. And although there are actually well-endorsed national and international guidelines on how to evaluate patients with hyponatremia, they are rarely used in clinical practice. As such, the clinical laboratory can play a role to highlight this for the provider. And actually, if you, as a leader of a hospital or organization, implement more reflex sort of testing, you can have an impact on potentially reducing the length of stay, which has a dramatic impact both on the outcome and on the financial outcomes, the clinical outcomes and the financial outcomes for an organization. So those are a couple of examples that I would give to show that the clinical laboratories, if viewed differently and used differently, can have a dramatic impact on both patient outcomes and the financial outcome of the organization.
Yeah, and I would just mention, those are significant things that dovetail into how clinical pharmacies operates as well. And, working hand in hand with the laboratory to get those alerts and be able to deal with them. And a lot of them are medication based alerts. So I just would share a couple perspectives. So since 2010, the VA pursued team-based care, and I would like to focus on that, a few comments on that for a minute. And during that time, we've not only implemented integration of clinical pharmacies providers into that team-based care, but we've also been tracking the outcomes. And so we have evidence, and we've published this in the literature, in the primary care literature, that when a clinical pharmacist is integrated into the primary care team, we were able to improve provider access by over 27%. And this 80% of that care that the pharmacist delivered was virtual. And so that goes to Dr. Loftman's comments earlier about virtual delivery. And we have significantly changed our model to be a lot more virtual, and there is no going back on that issue. We've also published and shown that integrating of the pharmacists onto those teams has decreased provider burnout. It has improved job satisfaction for those providers. It has improved patient satisfaction. And all of these are super important today in terms of retaining our workforce and then also retaining our patients within our healthcare system. And then lastly, I'll just comment that the pharmacist integration onto these teams, and again, we've published this data, have shown to significantly improve the quality metrics, such as the HEDIS data, and lower overall cost. And through the application of comprehensive medication management, and this has improved the financial stability of many organizations that have implemented something similar.
Trent, if I could just add one quick comment to what Anthony has said. The team increasingly has to be viewed as something that doesn't necessarily aggregate on a playing field at the same time. There's the potential to, as Anthony has said, virtually create the team, but the leadership of the hospital or healthcare organization has to provide the support and infrastructure to allow that team to exist. And from a clinical laboratory perspective, unlike some of the pharmacy models where you have a pharmacist actually rounding with a care team, the clinical laboratory can be a virtual way that can have a dramatic impact as well.
And Trent, and I might add, really taking parts of both of these excellent discussions is the team-based approach has also just the practical benefit of cross-silo discussions, which has a lot of value. And if you look at the example, Les and I were part of those discussions regarding NephroCheck, and the laboratory in isolation was thinking, oh, that test is too expensive. It's going to be difficult for my budget. I don't know if I should do it. The nephrologists and the cardiologists or the cardiac surgeons were saying, you know, we just did a heart transplant. You don't want to tell the patient good news, your heart's doing well. Bad news is your kidneys are failing. And the point is, and this is, and I know Anthony and Trent are very familiar with pharmacogenomics and have training in that. We kind of think along the lines of labocogenomics. We steal shamelessly from that. And, you know, it's not really about the price of the test as much as it is the value of the outcome, and avoiding that kidney damage that is very costly to society and to the patient long term. It makes the price of the test actually quite cheap. And then I'd extend it just the discussion just a step further and say that the lab in its new operating model, as it provides services across the health system's primary service area, it can help in the team mode for patient discharge planning, and get involved in providing tests and helping to monitor the patient as they move through the continuum of care. And as Les said earlier, trigger earlier interventions and maybe avoid some 30-day unplanned readmissions, et cetera. So in this new envisioned role, the lab can extend a lot of its key characteristics.
Thank you for those comments. It's very enlightening. I wanted to maybe target a question for you, Anthony. The VA clearly has a decade of experience in team-based care. How has that changed the way healthcare is delivered and helped define the roles and scope of practice for the different disciplines we're talking about? And what does the future of such programs look like?
Yeah, it's a great question, Trent. There are obviously growing pains associated with team-based care, and people need to understand that it's not about kind of trying to take somebody's job and that kind of thing. It's more about trying to figure out what value could be brought to the team by a particular profession being on that team. And we definitely have learned that over time. And I can just say that pretty universally, the teams within VA and primary care include nurses, of course, the physicians as kind of the team champion or team lead, but they include nurses, pharmacists, social workers, dietitians, all who have a very important role in managing the patient. And it really has relieved the primary care providers of all that stress and workload associated with doing some of these activities. And you can imagine, when you think about trying to get a patient's disease under control and having an adherence problem, or the adherence problem might be caused by the patient being homeless, which really needs a social worker. It doesn't need a pharmacist, it doesn't need a physician, right? It needs somebody else. And so the experiences over the last decade have been really great in terms of team building and understanding from each of the members where the strengths are and how to refer back and forth to each person. So we have pharmacists referring to dietitians, and back and forth. It's not just a one-way or two-way thing. Sometimes it is complex in terms of how they hand off patients to each other. I can say, it's not always universally applied, right? Some teams transition faster than others, and that's why you have NBA champions and you have other teams that are not, because they don't necessarily, they're all playing the same basketball game, let's say, but they don't necessarily view teamwork in the same way. So I think what we've tried to do is create more standardization and understanding and education to all the team members about what the role of the clinical pharmacist is and not what the role is not. And I think that's really important for the team members to really define those roles. And sure, there's going to be overlap, right? Doctors prescribe and they can monitor the drugs. But then when they realize that maybe the pharmacist is better at this or can do it more efficiently than I can, they start to hand off that workload. And that has really improved the stress and the satisfaction of our primary care and specialty care providers.
So
No
Trent,
doubt.
maybe to build on Anthony's comments a little bit, there's no question that alerts or suggestions can improve adherence to practice guidelines. That's absolutely clear. It's been proven. The pushback that I hear most is that providers have sort of alert fatigue. So they don't want to see any more of these alerts and everything. So we have to deal with that in some way. And actually the clinical laboratories and the pharmacy can participate hand in hand with some of these things. Take, for example, a simple thing like statin therapy for patients with hypercholesterolemia. It's been shown that alerts to identify patients who could benefit from statin therapy work. So leadership has to say, get over the alert fatigue. Let's work together, hand in hand, as a team, laboratory, pharmacy, provider, and agree upon the alerts that are meaningful in your practice for patient care. And those are the alerts that we should absolutely adhere to. And it will have positive impact on both the care provided and actually on both the cost and the revenue that a hospital or healthcare system will realize.
And if I could just add one other comment about that, because it's a great point, is that, we have created clinical dashboards, which take those alerts and put them into a population management tool where the pharmacist can just look at those alerts and look at, which patients have high serum creatinines, whatever, right? And have a targeted list of all the patients on a provider's panel. And then they could proactively go after resolving those issues without the physician having to see the patient again. And so it's part of their collaborative practice agreement with the team that you as the pharmacist will go after trying to correct all these things. And that's why I had mentioned earlier, we saw significant improvements in all the HEDIS measures by doing that, right? Because the HEDIS measures could alert, they'd be on the dashboard, the pharmacist could go in there and start to really target all of those things. And they're communicating with the team and with the provider, this is what I'm doing and how I'm doing it, but they're given the authority to do it proactively.
Absolutely. Let me take a moment to address the audience. If you have questions for our panelists, please go ahead and put those into the chat, and I'll pick those up and weave those into our discussion. I'd like to change our focus a little bit. Keith, I wanted to get a question over to you. I wonder if you could speak for a moment about some of the key laboratory capabilities that we should keep in mind as we think about team-based care. And I know Dr. Wold just mentioned alerts, maybe there's some others. And how do we want to think about tomorrow's lab model maybe in a different way.
Yeah. Well, thanks, Trent. Yeah, I think some of these characteristics maybe have not been fully recognized and certainly have not been leveraged to the degree they can and should be. But the laboratory, clinical laboratory, for decades, people have said and have known that it generates about 70 to 80% of the data in the medical record. And the other thing to keep in mind is it does that at about 3% of the cost profile in healthcare. So we spend about 3% of our healthcare spend on laboratory. So to me, that's tremendous operational leverage that we have not levered as much as we should have. The laboratory also, this data triggers or confirms the vast majority of healthcare costs. And as we move, and we've talked already a little bit about precision medicine, as we move into precision medicine, that impact is going to be even greater. And the interaction between pharmacy and the lab can be more direct with just sharing of information with the clinical team as well, because it'll be an if this, then that sort of scenario. It touches every patient's care in nearly every care setting. And it's a core competency in every healthcare system, and it can be leveraged even more fully to support care coordination, as well as these new care delivery models that we talked about. You know, there's literature out there that says these virtual visits aren't as effective as they might be because 30% of the patients don't get the laboratory testing done that they need so that the visit is productive. Well, if the laboratory changes its delivery model, there's an opportunity to really enhance and make these virtual visits as productive as possible. The other thing I think that maybe gets lost is the fact that the laboratory is a scalable environment. It has excess capacity concerning its plant and equipment after acute care needs of the hospital have been met, and that usually occurs in the morning. And so the diagnostic companies have created tremendous capacity in the platforms that are in the laboratories, and these can be used really to drive that integration across the primary service area for the healthcare system.
So one of our audience members, Garrett, thank you for the question, is asking, you know, we're touching on a lot of the impacts on reduction of care associated with team-based care. What other impacts? She's asking, what is the impact on overall patient experience and inpatient length of stay?
I think that's a great question. And there's, Keith and I have had the opportunity to work with a number of healthcare systems, and it's very clear, as a simple example, to try to answer that question, that that organizations or hospitals that have engaged in what has been historically called outreach, what we would call care optimization across the continuum, those organizations have a lower length of stay in hospital. So it reduces both their costs in terms of the inpatient care, and the provision of those services creates a new revenue stream for the organization. So it's a win-win scenario. It's a win for the patients, they get discharged sooner. It's a win for the hospital or healthcare organization because they have reduced costs and an increased and a new revenue stream.
You know, maybe another concrete example along those lines, and it's an experience that Les and I had together when we were both at Mayo, and that is the growth of Mayo Medical Laboratories while we were there. And it was of significant benefit to the institution in two ways. One, there was incremental revenue that was generated, but two, we knew because of the additional volume that was coming in, the patients that Mayo saw in Rochester, Minnesota got better diagnostic support than they would have had that volume not been available to support the lab and make it as service oriented as possible. So it's just to reinforce what Les just said, that extending the model for the laboratory from a service perspective out into the community can have tremendous benefits internally within the health system as well. I think too, it can, to extend a little bit into Gert's question, is that the laboratory can also help the providers come up with less variation in their diagnostic processes.
Yeah.
And in so doing, they can decrease care variation. And that really is occurring because they work together with providers to reduce or to align diagnostic pathways with treatment pathways. And that too, I think, obviously pharmacy gets right integrated into that continuum. And it just makes the health system work more efficiently. The laboratory, right now, because of fee for service, the laboratory is very transactional in its interaction. Here's serum succotash was ordered, here's the result. As opposed to serum succotash was ordered, oh, with this result, they're going to want to order serum squash. And so the lab and the lab information system, through reflex testing that Les referred to, and testing cascades and things like that, it can eliminate a lot of the back and forth for the clinician and take some of this inefficiency off. And in between each order and result, then there's time that has elapsed that the patient doesn't really enjoy, sitting in the hospital or something like that. So it can be a much more efficient process, and you can get a more definitive result in a shorter period of time and get on to the definitive treatment that you all would provide.
This is fascinating. I want to change the topic a little bit as we're getting into the last 10 minutes of our topic discussion. And I wonder if you guys could touch on the current state of precision medicine or individualized medicine, the impact of rapid diagnostic testing, and maybe even a little bit about the VA's approach on pharmacogenomics. If you guys could touch on that a little bit.
Anthony,
I'll start off and just to say that, the VA has been committed to all forms of personalized medicine for, well over the last 10 years or so, primarily in oncology. And that, of course, has been a big application everywhere. But things recently have significantly changed. And specifically is increasing recognition of the value of pharmacogenomics in medication selections, safety, cost effectiveness, especially in practice areas like mental health and other specialty practice areas. So leadership in the VA has determined that the clinical pharmacists were going to be the key professionals to move this practice forward in concert with the clinicians and with the laboratory systems that we have, as well as contracted laboratory systems to do pharmacogenomic testing. And recently they committed to hiring 120 pharmacists across the nation to serve as the champions to launch pharmacogenomic integration into all the healthcare systems across the country. So we have 150 facilities. They're hiring these first 120, which we're doing now. And as part of that, we're gearing up for advanced training of all of our 11,000 pharmacists that we have in the systems to solidify pharmacogenomics into the daily workflows. And it's important to recognize that pharmacogenomics is just one more piece of the puzzle when you're thinking about the appropriate therapy for a patient. You have to know renal function and the patient's demographics and all the other things, but applying and overlaying pharmacogenomics is going to be incredibly important. And I'll just mention that we have worked nationally, regionally, and locally with the VA pharmacies and the laboratories to really try and transform laboratory measurement of pharmacogenomics and its application, which includes, algorithms and information I think that Trent was just talking about is, what is the next step in this? So you get a PGX test, but that only tells you this one little piece. Now you got to match that up with all the other information you have with that patient. And then there's, the evidence that comes out of CPIC guidelines or other guidelines that are going to inform you about what the next steps might be. So, we've had a great working relationship at the national level with oncology, with the precision medicine, which includes all the clinical laboratory folks, as well as the pharmacy folks and the informatics people, to integrate this into a smart science that could be applied without wastage into the system.
So I might, Trent, just add to what Anthony has said that, if I were listening to this discussion in Middle Tennessee as a hospital administrator, I might be concerned about what the cost of all this is going to be. And I think that there's no question that there is some additional cost, but you don't need to go out and buy a next-gen sequencing machine and everything at this point. It is evolving, and there are already things that we can do to help in this integration of the laboratory information with the pharmacy and prescription. And as Anthony has said, it's not just the pharmacogenomics, it's whether the renal function, et cetera. All of that has to come together. And it's no question it's evolving. It will have a positive impact both on patient outcomes and on therapy. But don't be concerned that you have to go out and buy a next-gen sequencer tomorrow in order to realize some of this savings. It will come in time, at scale.
And I will just mention what Keith mentioned earlier. I love your statement, Keith, about it's not the cost of the test, but the value of the outcome. And I think what we're seeing is appropriately applied. It's not generally universally applied at this point in time because testing is so expensive, that it's really, what are you getting on the back end? And I think the value of having a one-time, even a panel genomic test on a patient, which lasts a lifetime, is going to be super valuable. Now, maybe in the first year, it's not as valuable as serum creatinine when you're actively treating somebody, but over time, patients are added on drugs where that laboratory test is going to be valid for long periods of time.
So we're down to just a few minutes. If each one of you could make a closing or summary comment, and if you didn't hit a primary point, you could weave that in. If you could take maybe 90 seconds each.
Well, I'll just start and be quick. I think there's huge opportunity for hospital and healthcare organization leadership to realize a new role for the clinical laboratories and the pharmacy, and to leverage that for better patient care and for the financial benefit of the organization.
And I might just tag on to that. And it's, laboratory initiatives, if we leverage those key characteristics that we talked about just a few minutes ago fully, can have an impact on the hospital's operating margin. And just because I like to quantify things, a 300-bed acute care hospital, if a number of the things we have talked about have been fully implemented, it can have a $10 to $15 million a year impact on the operating margins. So, and obviously that's a favorable fact for rating agencies, which is very much a focus these days. And getting into this space is relatively low risk. There's a lot of sunken costs in the laboratory already. And that, as we've said, the instrumentation has excess capacity. And so you can grow the business, you can generate revenue in this existing reimbursement environment while you position the healthcare system for the new reimbursement environment that's coming. So I think that there is a lot of exciting opportunities to be explored.
So I have a couple final comments. One thing I think folks can do differently starting tomorrow is really to explore how your system utilizes clinical pharmacists and clinical lab, recognizing that they are often very underutilized but highly trained individuals. So when you think about their training and background, and you may not be leveraging what you already have in terms of skills at your facility. Most states now allow broad collaborative practice agreements between pharmacists and physicians that can be leveraged like never before. And so the time has come to really integrate them into team-based care to reduce provider burnout and turnover, as well as improve the patient experience.
Great. Thank you very much. I want to thank all of our panelists here today. If you'd like to do an emoticon, we can give a round of applause. Really have learned a lot today from you, and very much appreciated. There is another question in the panel, but I think what we'll do is maybe follow up afterwards around examples of length of stay reductions. And at this time, I thank you for all of your attention, and I'll turn it back over to our host. John?
All right. Well, thank you, everyone. Fantastic job. Love learning about this. I know, you probably try to figure out how do we not try to cover everything. And I know this is a very deep and broad subject. So, hopefully looking forward to a phase 2. Maybe in the fall, we'll come back and dig a little deeper and wider and be able to do that. So I'm looking forward to that. Just wanted to mention to folks that coming up next for the chapter, we have new member orientation, or if you've been a member for a while and you're just starting to get involved and you want to understand more about the chapter, we do have an orientation coming up. So you can, email us, contact us, and we'll make sure to get you plugged in. And then also June 22nd, our membership ice cream social. So looking to reconvene and network and socialize. So be looking for that coming soon, and hopefully it'll be nice and hot out, and get some good ice cream there. So, and then lastly, 2 things, and I'm going to go ahead and put the link to the survey in the chat. Since this is a qualified education event, we ask that you take 30 seconds, complete this quick survey. And also, for those of you that are working towards your fellow, you will self-report the qualified education credit, on your account at ache.org. So if you're not familiar with how to do that, just go onto their website, and you should be able to, click on My ACHE and then follow the steps in the menus there to report your qualified education hours towards your ability to get your fellow. So I urge you and encourage you to do that. With that, go ahead and complete the survey, and that concludes the education portion of our session today. So with that, you can take a second here. I just used the last second, so it's now at the end of the hour. So appreciate everybody's involvement again. More appreciation to the panel and to Trent for moderating, and this is just a fantastic time. So with that, everybody can drop off, and I'm just going to ask the panel and moderator to stay on, and we will just catch up afterwards, so I can thank you personally. So again, thanks to everyone for joining, and look forward to seeing you at our next event. All right, I think that's it. Well, great work, everyone. I think we are the last ones here.
You guys really had good commentary, and I thought it flowed really well. I really appreciate it. It's one thing when you have prepared and you think you've kind of understand the topic, but when you also are picking up new tidbits along the way, it's really a good program.